ward. So if there we go. So if you have to leave early or you want to see any of our other previous sessions, there is a YouTube channel linked to these grand rounds where you can catch up on that. The final thing is when you first tuned in, if you were on the earlier side, we had our spotlight on display, and that's a monthly or a quarterly newsletter that we have created as a department, which highlights a global health issue that's relevant to work both in Bristol and across the world as well. All right, back to you, Rihanna.
Perfect. We'll go ahead and introduce our first set of speakers. We have with us Cordula, Milka, and Lorna, who have been nurses for a long time in the Nanyuki Teaching and Referral Hospital. Unfortunately, Milka and Lorna have not been able to join us, but we do have Cordula, and we can see her. Hi, Cordula. Cordula and Milka have been working as triage nurses in the emergency department, and Lorna has been supporting them until recently. As I said, unfortunately, due to technical issues, Lorna and Milka won't be able to join us. However, Grace has been very kind enough to record and prepare an interesting pre-recording session for us. And we would be sharing the work these amazing ladies have been doing and putting in the triage at the Nanyuki Hospital. We will be taken through their challenges, the future, and the process of triage in the Nanyuki Teaching and Referral Hospital. Thank you so much, Grace, for recording and preparing the session. Cordula is available and she will be able to answer all questions in the end. Grace, I would request you to now kindly share the screen and play the video for us, please.
Thank you. Can you see that?
Mm-hmm.
Perfect.
Before the existence of triage in NTRH, in fact, most of the patients used to succumb because they could queue up with other patients because they could get maybe only 2 clinicians in outpatient out of maybe 100 and something patients per day. So most of them, in fact, they used to succumb in the waiting bay because maybe that time there's no time to take history, suffer and move. Because most of them even could succumb while still on the waiting bay. Patients used to take a lot of time. Yeah.
Okay, how are you? Okay, we'd like to be talking about the triage before, like, you came on the board. Like, we had some problem with our patients because we didn't have the, like, because we believe, like, a triage is a heart of the hospital. So before we didn't have that heart of the hospital. So patients, maybe most of them, they were treated in places that are not supposed to be treated. Maybe some they had emergencies, but they never got that chance to be treated early. So like before, like our doctors had a lot of time because they had to triage the patients. Maybe patients of high blood pressure, they were not yet diagnosed because in the triage, right now we have a easy time, like we can diagnose them at the early stages and we repeat it severally and we advise them and we escort them to the nurses and to be given the medication to lower their pressure, and we repeat it multiple times. But the time before, it was like crazy because they had to go to the doctor. Maybe the chances were not that well, and doctors has a lot of queue. So he has no time to take care of that patient throughout. So he missed a lot of opportunity.
Even others used to be threatened by relatives, even being beaten by relatives because of they could not understand whether maybe there's a delay. When there's delay in maneuvering the patient to the clinical officer, always there could be chaos. In fact, even physical fighting. Yes. The patients used to be too many, no direction. They are mixed up. Yeah. For the Dharura, there was no triage at all. We used to overwork. In fact, we used to see all the patients in outpatient, no triaging, no nothing.
Any emergencies come through, it's detected fast in the triage, and they are directed to like prices.
the triage now, we have got a lot of confidence with our emergency department team, where when we triage, they're on their feet to call the EMOS. Now Dharura, since Dharura came, in fact, it's perfect. We know how to triage, and now patients are enjoying because they're going to the respective areas where they get first aid.
Triage forms which made the work easier. Yeah, now the patients could be taken out to the patient, emergency, and the time was good. Yeah.
Right now, we're in a good position that we say our patients are getting the best care and they are treated well and they are taken to the, if they're emergency, they are taken to the emergency. If they don't have any like emergency, they are taken well.
Oh, because there is the existence of triage in NTRH, there are no chaos between relatives and staff. Because when relatives bring in their patient who are very sick, they need first attention. And maybe there are only 2 clinicians. Now, because the triage has really decongested this, because most of our sick patients, very sick patients, when we triage amber flag or a red flag, we always take them to emergency department. That's now decongesting the outpatient department, and there are no more care. Triage has done a lot of good work for our hospital. Now we are really decongesting the outpatient department. We are only taking there stable patients who can even wait for even 2 hours on the queue before they are seen. But in triage, we take those who are urgently, who can even succumb before even 30 minutes. We take them to emergency department for more investigations and more management, senior management. Now the challenges were, especially when there's an accident, everybody could just flop in, even the relatives could flop in the outpatient, a lot of cares and congestion. The clinicians there could get confused because they have to call the MOs on duty to come and assist them. But nowadays, since Dharura came, you can get a lot of care in ED, through ED, because you triage right away from the ground. Then you take the injured patients to emergency department, where they are prioritized and given efficient and a very complex management.
About the challenges we had before, it's like a patient didn't understand the reason of coming to the triage and why they should be triaged. Because most of them felt like it's time wasted and they needed to see the doctor without getting triaged. But we overcome it because we explain to the patient that they need to be taken the pressure, taken the history that make us understand and to be able to identify if the patient has an emergency treatment or it just like you can just go to the consultation without any assistance. So the patient through that, they understand it. And right now, I think we have in a position that patients understand, and even the doctors understand that like every patient has to pass through triage. So it has become easy going for us. And and we have also have like posters that have been posted in the outpatient consultations and everywhere in the hospital that makes people understand that triage is the most important thing in the hospital and it's the first treatment. Because if you're diagnosed with anything or any emergencies come through, it's detected first in the triage, and they are directed to the like prices. Then more maybe more education for the patients, and we continue. The education is there, but I think every time, because we are getting new patients from every day, so it's good triage can be put there, because right now in our hospital we don't have a real triage. So I feel like maybe it could be addressed and we could be having a real triage that patient they can be like this the start. Before, like the way we have so many places that every patient know that they have to register before getting any service. So I think it should be also the triage that is a place that is real triage, not moving, because we have been having challenges of moving this way. So patients, they are getting also confused that where is the triage? So I think it's good, like we having a triage that is written triage and everything, and it will be helping to the clients, because I think our community are the people who want to be helped, and they feel like if they get best help, they can. So
Yeah, the challenges that we're having in emergency department, we have got only 3 beds and 2 stretchers. You see, when you have got a mass accident, you cannot accommodate everybody there, because there are only 3 beds and 2 stretchers. And you see now, you cannot put a patient on the floor, or those bleeding, you cannot make them share the beds or the stretchers. So maybe in future, because they are they are putting up a new emergency department and triage department, we hope for the best, because maybe they are going to purchase for more beds.
okay, I would like to address some cases that we found in triage. That's why we are saying that triage is helping a lot, because we had a case of an age of 17 to 14 years child, is a girl, and we discovered like the patient had a bleeding that was non-stopping. So the patient was carried red, that was supposed to be taken to ED. The patient was age of 17 to 14 years old. She was had abortion that was incomplete. So the patient was not that free with the parents, like we cannot express everything, because abortion in our country, in our community, is a crime. So not everybody freely to talk, but in triage, I'm thankful because we have the nurses that are so friendly to the patient, that the patient gets openly and they can share their problem and say something that you cannot say to the relatives or the person who brought her to the hospital, because we make like patient information, they are kept confidentiality. So the patient came and explained everything to us, and the bleeding was the patient was like getting pale. So we realized it, and the patient was rushed to ED, and afterward was taken to the ward.
There's a lady who came with the infertility. Then she had a very negative attitude. But when I talked to the lady, she calmed down. So that's the time I took the action of referring the patient to a clinician and making a follow-up so that this patient can be booked a gynecology clinic for review by a gynecologist. Thus making the patient have hope of conceiving.
There's a patient who came with the to ICU, and she was taken care of very fast. And she came out well. And she came to thank us for what we did. Yeah.
Also, there was a middle-aged man who came to triage with a difficulty in breathing and low respiratory movements. I went and took a wheelchair. Then I tried the patient, took a wheelchair very fast, and took the patient to emergency department where they did the CPRs. So I say it's a success, because if it were the way it used to be formerly, the patient could have died, succumbed on the queue. Yes, example, when maybe there's a snake bite, that patient, we have to ask the type of snake, the color of the snake, the time that the patient was bitten. Then we tried the patient to emergency department where they are given venom and maybe even hospitalized, because depending on the patient, there are other snakes which are very poisonous. They make patient vomit, they make patient to feel chills, and even to have a DIB. There's a middle-aged lady, a young lady, sorry, in late 20s, came with a puffiness of the face, diminished output, edema of the body, then with the DIB. Then when I tried to ask her questions, she had She was in pain that she could not talk. Later, she calmed down. Then she told me she was taking a lot of water, but the urine output was diminished. That time I took action. I took my observations. They were not normal. The BPs were elevated. I wheeled the patient to emergency department, where the patient was stabilized, then later taken to the wards after the lab requests results were out. She was found to be having renal failure. Currently, the lady is still going on with the dialysis. She comes twice a week. Triage in Kenya in future, it will be something very nice because we'll be classified like the KNH, the Kenyatta National, the National Referral Hospital, the KNH, because we'll have time to know which patients belong to which doctor or the specialist. Then maybe in future, we'll have a lot of people specializing for the kind of illnesses or diseases that we encounter in triage. Because right now, when we get something like maybe hemophilia, we have to refer that patient. But when we triage them, when there are many, then maybe the hospital will consider the training or specialization of our MOs, even nurses. Yes. I can take example from where I come from in Western Province. There's no triage there. Then there are a lot of snakes, there's a lot of malaria, there's a lot of sickle cell, there's what. So when maybe the Dharura extend their departments to other hospitals in Kenya, I think it will be easier for them to be triaging the patients, then channeling them to wherever they are supposed to be channeled. And there'll be maybe the death rates will go.
When I see like triage in future in country and in this hospital, I can say that it's a good start and it's a good thing because we are in somewhere that I could like even in rural areas also to have the same programs. Because when we have when Grace came and others came, Elena, Jordan, and everybody, they were able to coach us on writing triage papers that we are able to diagnose easily and to get the history of the patient that help us to help the doctors also to reduce the queue in the clinic office, like in the consultations, because you write the history if the patient is using any medication, is he has any allergies or anything, so doctor is able to detect before. Because if the doctors have a lot of work, they're not able to ask all questions for the whole patient and took the history. But the triage being the art of the hospital, I feel is a good start, and I could like even the program if it could help us go to the rural areas that we have so many hospitals. And right now in Kenya, we feel like rural areas, there are people going there because they feel like in rural areas, like in the health centers, they don't pay much, not like in the referral hospitals. So a lot of patients, they are in the rural areas. So I feel the program can also be here, but still can move to rural areas because we feel a lot of patients, they are there and they're not getting the feel there. There is treatment. So like for pressures and DMs and everything, I think is a good start for the hospital. And you have seen like entry rate growing so fast and making like the whole hospital understand like triage is the heart of the hospital and everything is working well with us. So I could just say like, I love it. And I would like it to be focused. Like we have our neighbor hospital, is like our small child, is in Liki. There is another one in Kararo. There's a lot in Kenya, but in Laikipia we have so many. In Doldo, we feel like if the program expand and get to catch up the other health centers, you're going to be in a good position and you're going to help so many patients to diagnose their diseases and to get best care. Thank you.
Just about what I've said is when maybe we get chance to go to UK and maybe see how they carry on their triage, because we have not seen them, but we are being taught, like, for example, like Grace, Elena used to come and teach us, and currently we have gotten Grace, who is doing her best, and Tia is coming. So maybe when we get that privilege to go and see how triage goes on in UK, we can do better.
Thank you so much, Grace, and thank you, team. It just makes us kind of realize the importance of organization and having standardized processes in place. That was really good. I think Cordula is still here. Cordula, are you still here? Is that Judy? Anyway, we can take questions now or in the end, and Grace would be happy to answer them on their behalf. Grace, do you want to take questions now or in the end?
I think if Cordilla is not there to answer questions right now, maybe we can see if later on she will be. I think
Okay.
or we could always organize to phone her. I'm happy to answer questions at the end of my presentation, which might answer both, but I think it's probably better to come from the Nanuki triage team rather than from me
Yeah.
on some subject.
So if I hand over to Joey to introduce you, and I'll try getting in touch with them soon. Is that okay?
Yeah. Yeah, perfect. Thank you so much.
Over to you, Joey.
So we would like to introduce our second speaker, Grace Darmanin. Grace was recently working with Dharura and the BRI as a senior staff nurse. She's currently joined us from Thailand and will be taking us through her audit on hospital staff's perception on triage tools in a tertiary care setting in Kenya and an evaluation of its completion. Over to you, Grace.
Thank you. Can everyone see my screen? Yep.
Yes, thank you.
Thanks. Perfect. So I think this kind of nicely follows on from the presentation you just watched from the triage girls in Nanuki. So basically, when I was in Nanuki as one of the Dharura nursing fellows, I completed a interview audit on the hospital staff's perceptions. So as you've just seen the triage nurses' perceptions of the triage tool and how it's working. This kind of goes into how the rest of the team in outpatient department and emergency department feel how the triage form is working. I also did a compliance audit of the completion of the triage tool. So for any of you who don't know, I think we've covered it a little bit, but Dharura is a global health partnership based in one of the hospitals in Bristol. And we have fellows such as myself, Joey, Tia, Rihanna, who are currently out in Nanuki working with the team there. So the triage tool that is currently in place in Nanuki is a tool that has been developed over time by various fellows overseen by the Dharura leads. And it currently follows the EMKF guidelines of kind of a red, amber, green system. So red is the most acute patients who get moved straight to the emergency department. And the amber patients can go either to the emergency department or to the outpatient department. And they're kind of the next most urgent patients to be seen. And then the last category is green, and they're patients who are safe to be waiting. So we looked at the tool, and it kind of follows, this is a EMKF guideline, which helpfully kind of shows some red flags. So things to look out for patients in the red criteria, yellow criteria, green criteria. You heard the triage nurses earlier talking about triaging someone as red, for example, the heavy bleeding in pregnancy, or post-pregnancy. So when you heard them talk about that, that's what they've done. They've triaged that patient as red, and they've gone straight to the emergency department. So these are all Emergency Medicine Kenya Foundation guidelines that we follow in triage. This is the most up-to-date version of the triage tool that we use in Nuniki. So as you can see at the top, it's got the patient's biometrics, the observations, and the total use score, pain score. And we do have a space for a random blood sugar, but at the moment we're not currently doing that in triage, but that's something that could be developed. And then we have the red, amber, green category, which gets circled by the triage nurses as to which category they think the patient falls into. Then the triage nurses record presenting complaint, if it's relevant, the last menstrual period, history of presenting complaint, signs and symptoms, past medical history, current medications, allergies, and then they sign their name. And then at the bottom, you'll see it says received by. This is to be completed by the clinical officer, medical officer, and what area they have received them in and the time. So the audit of this is 10% of the daily collected triage sheets were randomly selected to audit, to look at the compliance of completion. So we had a look at comparing every month, but for the sake of this presentation, we just look at the difference between November 2024 to March 2025. And just to see how the global partnership of working closely with the triage nurses and how that improved compliance and the improvement of compliance over this time of completion of the tool. And then secondary to that, there was a structured 11-question interview conducted to analyse the perceptions of the nurses, doctors and clinical officers working in NTRH in Nuniki. We looked at 20 members of staff were interviewed for this, and they were proportionally representative of how many doctors, how many nurses, and how many clinical officers are currently working in the emergency department and outpatient department. A thematic analysis was then conducted by 2 people and compared to compile the findings. These were some of the questions that were, or all the questions that were asked in interviews. So looking at the compliance, this is the November compared to the March of how many of the triage forms were fully complete. As you can see at the beginning of November, just over 50% of the triage forms in total were complete. And comparing that to March, it is just under 100%. And some categories are filled out 100% for every single patient that passes through triage. This study is currently ongoing, and auditing is continuing to monitor this. So, and then looking at these are the findings for the questionnaires that we had. So questions 1 to 3 are looking at what was happening before the triage tool was implemented. 14 people said that it was labor intensive and it was unstructured. A lot of people mentioned a lack of a formal triage system. Lots of people said that they would write some of the vitals on the back of the patient's payment receipt, and then they would take it to the doctor's office. It sounds like very few patients were prioritized based on their severity. Most patients would get lost in the hospital. And one of the clinical officers even said that they would sometimes find patients who had waited a long time in outpatients who needed to be seen for like ENT, ear problems. They'd then end up waiting the whole day. And by the time they were seen, the outpatient department clinic that they needed to go to was already closed. So these are the problems that were coming up regularly when we asked people what was happening before the triage tool. So then questions 3 to 8 kind of focus on the benefits, the challenges, and what's changed from using the triage tool. So 14 out of 20 respondents said that it was improving patient prioritization. They overall saw a positive impact, faster decisions and more focus came up a lot. Lots of people had an ongoing desire to continue to improve the service. There was quite a few people were talking about challenges about it not being 24 hours. At night, there would be a lot of chaos again. The emergency patients were being taken directly to the emergency department and not through triage, which I think Lorna kind of brushed on in her presentation. She mentioned how some people didn't know where triage was, and there's still not a permanent place for triage to be. So people were saying that they think, so quite a few of the medical officers and clinical officers had the impression that they think there needs to be more triage nurses, and that they're having the challenge with the venue as well. So that those things were coming up often. One person did say that as one of the benefits, that they think that they had noticed a reduce in number of transfusions for vaginal bleeding and ectopic pregnancy patients. There's currently no statistical evidence for this, but that's something really interesting that is a perceived improvement from the triage tool. So it'd be really good to look into this further and see if that is a benefit from having triage. So then questions 9 to 11 were about the global partnership with Dharura, asking people what their understanding of the Dharura partnership was and what they think the future potential is in NTRH and in the rest of Kenya. So we 20 people, which is 100% of interviewers, said that the global collaboration could successfully be used elsewhere in Kenya. They think that this model is working in NTRH, and they think that it could be used and implemented in other areas in Kenya. So 13 people responded, mentioning about Dharura assisting in simulation and training. And I think this is through people like Rose, who works with Dharura, doing sim. And I think one of the really nice quotes that came out from the interviews was, every time I see your the blue scrubs, I know today there will be some learning somewhere. I think that kind of shows what people think when they see Dharura fellows, or they see people like Rose working in Nanuki for or with Dharura, and the emphasis on training. People were saying that they'd seen a positive improvement in patient care and safety, and they were saying that other rural facilities would benefit them. And I think, as you heard Cordilla talking about the benefit that could happen in Western Kenya, where she's from, or people like Lorna was saying about how there are other rural areas like Dodo, Leaky, where they think that triage could be beneficial. So I think in conclusion, overall, the perceptions were positive, and the implementation of the triage system, I think that the Global Health Partnership was perceived to strengthen education and training and supporting triage. And there's definitely a perceived benefit to future working in other healthcare settings. It's hard to directly assess clinical improvement, so there's limited recordings of outcomes of patients. And I think, for example, the reduced number of blood transfusion is what one of the ED doctors said was a benefit. It'd be great to do some further research into that, and there's lots of further projects that could definitely be taken on from this that I think would add really useful data to support the use of triage. So there are some ongoing concerns of sustainability and physical resources. For example, some people were talking about how, like, the equipment in triage, the location of triage, and training new triage nurses, if we wanted to go for 24 hours, because at the moment triage runs from like 8 till 4 every weekday, or every day, sorry. And one of the limitations to this study is that all participants were aware that the interviewer was a Dharura nursing fellow, and so this does add a bias to some of the interviews. And then another limitation was that all staff interviewed, they do practice healthcare in English, but there was still a slight language barrier with some people with some of the questions. And then just some other things is ethical approval came from Dharura, permission from Esben, the CEO of Nanuki Teaching Referral Hospital. We discussed this with ED and OPD nurses in charge before we did our interviews. Information sheets and consent forms were completed prior to all interviews and for each participant. And I'd just like to thank the leader team of Dharura, so Sarah, Andy, Chris, Claire, and the Dharura Global Health Fellows who contributed to this. So Helena, Ian, Matty, Zoe, Ash, Chintan, and the Nunuki Teaching Referral Hospital team, Esben, Janet, and then all of the ED and OPD staff that took part in this study. Thank you. Does anyone have any questions?
Amazing. Thank you so much, Grace. It was so nice to hear from both sides, so from the triage nurses themselves, and then from fellows who've been involved in implementing the triage tool. Has anyone, I've got a few questions myself, but has anybody got questions either for Grace or Rihanna, have we got any of our triage nurses present?
Cordilla is on there
Cordilla's
again.
here.
Cool. So we can kind of open questions up to Cordilla and also to Grace, if anybody has any. If people are still thinking of questions, I've got two, if that's all right. So one for Grace and then one for kind of anybody. So the first thing is, Grace, you showed us the compliance of completing the triage tool that was with data taken from November and from March. And in March, we saw an almost 100% compliance that's kind of looked as though it had increased fairly significantly since November. Had anything changed in that time? Had there been any interventions that had caused that improvement?
So I think the interventions from then was direct work with the triage nurses. So the nursing fellow from November that then overlapped with another nursing fellow into April was spending more time directly working with the triage nurses. I think this mostly improved their confidence, and obviously, so this study, one of the limited, we didn't look at the content of the triage forms. This is purely on the like compliance of completion, but I think that it's definitely I think it definitely shows that close partnership is something that has impacted this. I think so it's currently continuing, and I think that would be interesting to see what the further results will be from, I think, so I did a little bit in April, September, and then Tia is now continuing some data collection. And I think it'd be interesting to see the next couple of months of data collection and seeing how this is going. But yeah, the triage nurses are doing a great job.
Cool, thank you. And then I guess that kind of ties in with the second question I have about the sustainability of the project that you mentioned. So you said that some of the responses in the questionnaires was about there was concern about the ongoing sustainability. So both Cordilla and Grace, have you got any ideas of how this can be something that we ensure is used and implemented well into the future?
Pardon? I've not gotten your question.
So my question is, do you have any thoughts about how we make sure that we keep using this triage tool? So sometimes it's helpful when the fellows are there with you guys at the triage station. Do you think that without the fellows being there, it's something that you'll keep using?
You're not clear.
Was that not clear?
I'm not getting you clear.
So my question.
I'll just quickly text Judith the question.
Cordilla, can you hear me? Cordilla, am I clear?
Yes, now you're clear.
Yes. So Joey was asking that what
Yeah.
plans do you think, how do you think you'll be able to sustain this once the fellows leave, once the Dharura fellows leave? And how would you be able, how are you planning to sustain this by yourself?
I think when we will be taken through a training, we'll sustain it. And when we have a spacious room for triage, we'll sustain it to the end. And we'll make it.
I
Plus
think
equipment.
I think at the moment there's some of the limitations are the physical building of triage and the equipment is there. I think definitely not the lack of willingness or people who are triaging. I think it'd be great to see further focus on triage going into the future. And I think it's starting to be more recognized by the people in charge. I don't know if Cordelia agrees with that.
Yes. When you get room for triage plus equipment, we are going to work very hard.
You already are working very hard.
Amazing,
Yes.
thanks. That's really helpful to know. Thank you both for those answers.
Joey, you're on mute.
Sorry. I was just going to say we have a comment from Brendan that I can read out. So he said that triage is interpreted as a tool used only in an emergency brought to emergency care and A&E. However, the outpatient doctors are not sending critical patients to the emergency care, but rather sending home. This has led to MI patients being sent home, HPT emergency patients being told to come back the next day, leading to strokes and death. The triage model needs to be reassessed by the Ministry of Health and the Social Services, hospitals, the need for training to identify high-risk patients. And then reluctant doctors coming out after 5 p.m, taking hours before arriving, though there's no distract greater than 15 minutes from the hospital. Thank you so much for your comment, Brendan. And am I right in thinking you're talking about Namibia, or is this Kenyan healthcare?
Hi, Joe, can you hear me? Yeah, this is Namibia healthcare. So it's more directly in line with Namibia. And it's just a problem you always face. And I think across Africa, you can incorporate that it's just something that we face everywhere. Not just Namibia, but Kenya, anywhere. I think they sit listening to what's going on. It happens in the same places.
Yeah, thanks. And I think definitely I can recognise that in Zambia, where I'm based at the moment as well. Amazing. Has anybody else got any more questions or comments for our team today? Maybe not.
Joy,
Yeah.
can you hear me? Hi, it's Sarah from the UK. I'm one of the nursing leads. I don't have any questions, but I just wanted to thank everyone that has been involved so far with this project. I had the privilege to witness the development that triage has gone through in the past few years. I, for the first time, went to Nanyuki in 2020, actually 2021, sorry. And in the past few years, I've seen how hard everyone involved from the Dharura side and the triage side and the ED side and OPD side has worked towards these results. And I guess my message for everyone that is listening to us from maybe another country or Kenya itself is that don't ever give up to get triage working in your environments, but also be wary that it takes time. And there are a lot of challenges, as we have heard from Cordelia. starting with not necessarily having a place where to base themselves to do so. And often that's because when the hospitals were designed, the triage was not yet part of what it was intended to be part of an emergency department. So sometimes, yes, things would be difficult, but I think Nanyuki Teaching and Referral Hospital is a great example of how things can move forward. And my wish and hope for us and Nanyuki is that we are only moving forward. Little by little, we will make this better and better, and I have no doubt we will get there. So thank you very much, Cordelia. Thank you very much for everyone that worked behind this project, and thank you, Grace, for the great presentation, nice video. Thank you very much.
Thanks. I'd just like to thank Cordelia and her family as well for helping her to be on Zoom with us today. It's been great to hear from you, Cordelia. Thank you.
I'm grateful, Grace, because my family has helped me to join the Zoom meeting, and I'm very happy. And I promise to work harder, tirelessly.
You work so hard already, Cordelia. Thank you so much.
Yes.
Amazing. Yeah, it sounds like you work hard enough, Cordelia. All right, so I think thanks so much for your comments and for answering the questions, Cordelia and Grace. I think that brings us to the end of today's ground round. So Rihanna has put into the chat function the link for the feedback form. And once that's been filled in, you'll get an attendance certificate automatically sent to your email. So please fill that in, and that will just help us with the future of the ground rounds and the topics that we cover, and it will give a bit of feedback to our speakers as well. So yeah, thank you so much. The next ground round is going to be on the 12th of November. There's a WhatsApp group that you can join if you want to keep up to date if you're not part of it already. And the final thing is for the spotlights on. So that was what we had up at the beginning of the session, and I think we can put it up again now so that as people leave, you can stay and just have a quick read of it or screenshot it as well. But if you'd like to be involved in creating one of the future spotlights on, then get in touch with one of us. We're in the admin for the ground round WhatsApp group chat, and then we can put you in touch with the right people. Rihanna, is there anything left to say?
No, that's pretty much it. Thank you, everyone.
Thanks for joining us.
Thank you, everyone.
Great. Cheers, guys. Thank you.
Bye-bye.
Bye, everyone.
Bye.
Bye. Good night.
Good night, Cordelia.
Good night.
Good night.
What do you end this? Not to stop sharing.